Today, we will be discussing the 2020 Surviving Sepsis Campaign International Guidelines for the Management of Septic Shock and Sepsis-Associated Organ Dysfunction in Children. And in part one of the summary today, we'll be looking specifically at the screening, diagnosis, and antimicrobial therapy recommendations. So for the purposes of these guidelines, they're focusing on the treatment of both septic shock and sepsis-associated organ dysfunction. And so as a review, septic shock is defined as severe infection precipitating cardiovascular dysfunction, which is defined as either hypotension, need for vasoactive medications, or impaired perfusion in a pediatric patient. In terms of sepsis-associated organ dysfunction, that is defined for these guidelines as severe infection precipitating either cardiovascular or non-cardiovascular organ dysfunction. And the reason they focus on these elements of the sepsis of spectrum is that they account for the large share of morbidity and mortality in pediatric patients. So the first recommendations are that anytime an unwell child presents with concern for sepsis, they need systematic screening to ensure timely recognition. And the reason they make this recommendation is that timely recognition of sepsis has been shown in many studies to improve both morbidity and mortality. And so what they mean by systematic screening is that a screening protocol should be enacted that is tailored to the patients of your institution, the resources you have available, and the procedures performed in your institution. So for example, if patients are from a population with a high rate of immunodeficiencies, such as bone marrow transplant in a large center, those patients should be treated differently than patients presenting at a community hospital without that risk factor. Secondly, with regards to the measurement of blood lactate, the campaign was unable to issue a recommendation regarding the use of blood lactate to diagnose and screen for sepsis. There are no good data currently to use the blood lactate level in order to stratify a risk of mortality from sepsis. There is not currently a agreed upon cutoff for lactate levels to determine risk of mortality from sepsis, but it is an important part of the picture. And that's because we know that blood lactate is an indirect measure of tissue hypoperfusion. And in a study cited by the campaign, they found that a blood lactate level of greater than 2 versus less than or equal to 2 was able to be a good cutoff point for mortality. And additionally, rapid normalization of blood lactate has been found to decrease the risk of persistent organ dysfunction in patients with sepsis. So it's definitely an important part of the picture, as we said. The third recommendation from the campaign is that centers should have their own institutional sepsis management protocol, which has been shown in many studies to improve mortality, length of stay, and duration of organ dysfunction. And so what they mean by a sepsis management protocol is a sepsis bundle, or a group of orders, interventions, diagnostic studies, which can be performed rapidly when a patient screens in for sepsis in order to accelerate their care and improve outcomes. And in several studies, this has been found to have a decreased adjusted odds ratio of mortality as much as 5-fold in some studies, so adjusted odds ratio of 0.2. The fourth recommendation from the campaign is that blood cultures, if at all possible, should be drawn before the administration of antibiotics. And that is not to say that blood culture obtaining should delay the administration of antibiotics. However, because the identification of pathogenic organism in a septic patient is crucial to their care and their outcomes, it is important, if at all possible, to obtain blood cultures and additionally other body fluids, which may be helpful in terms of diagnosing any pathogen precipitating sepsis in these patients. Next recommendations have to do with the timing of antimicrobial therapy. And so this is broken down into the two levels of severity of sepsis at the outset. So first is patients that present with septic shock. The guidelines strongly recommend that those patients should receive antimicrobial therapy as soon as possible or within 1 hour of diagnosis of sepsis. And this data comes from 2 retrospective studies, which when they pooled the adjusted odds ratio of mortality, they found that this approached significance. So as you can see, the confidence interval crosses 1, but This coupled with much adult literature, which shows that improved outcomes with administration of antibiotics within an hour in patients with sepsis, means that the guidelines strongly recommend this for these patients who present with septic shock. Now, to differ, patients who present with sepsis-associated organ dysfunction without shock have a slightly different recommendation. And so according to the campaign, these patients should undergo a rapid, expeditious evaluation in order to get more information regarding the degree and nature of their sepsis. And as that is occurring, those patients should receive antibiotic therapy within 3 hours. Now, the reason for the difference between these two timelines is that patients with sepsis-associated organ dysfunction without shock versus those with septic shock actually only had a difference in their mortality after 3 hours of time had passed since recognition of sepsis. And so in terms of the absolute data used, it was only borne out to statistical significance at a 3-hour time point. And that is to say, if this patient does develop sepsis or septic shock within that 3-hour time period, they should immediately receive antibiotics, but the data does not support earlier administration being related to improved outcomes in patients who have organ dysfunction but not shock. Next recommendations regard the selection of antibiotic therapy. And so in terms of initial antibiotic therapy, the campaign recommends that these patients should receive broad spectrum antibiotics to cover all likely pathogens for that patient. And so the way we would determine all likely pathogens is based on a host of demographic and other specific factors for that patient. And these include their age, the site of a potential infection, any concomitant diseases that they present with, also any comorbidities, any indwelling devices such as central venous catheters, if they've been recently hospitalized, as this can affect the potential organisms involved, and if they're affected by any chronic colonization of bacteria. So for examples, the campaign gives several concrete examples of antibiotic regimens for different types of patients. So for any previously healthy patient who presents with community-acquired sepsis or septic shock, they should receive ceftriaxone as it's good coverage for both gram-positive and gram-negative organisms, and these account for the large majority of mortality and morbidity in pediatric sepsis. Additionally, in areas that have a high prevalence of methicillin-resistant Staph aureus, which is becoming a large part of the country, those patients should also empirically be covered with vancomycin, as this covered these organisms. For patients who have a higher risk of resistant gram-negative organisms, they should be covered with either an aminoglycoside or a carbapenem antibiotic. For patients who have a history of immunocompromise, they should also be covered with better pseudomonal coverage, including cefepime, any carbapenem, or piperacillin and tazobactam, aka Zosyn. For neonatal patients presenting with sepsis, they should be covered additionally with ampicillin to cover for Listeria monocytogenes and acyclovir due to the risk for disseminated HSV in a neonate. For patients with potential intra-abdominal source of their sepsis, they should be receiving anaerobic coverage, which can include piptazo, any carbapenem, or metronidazole or flagyl. And then for timing of sepsis, for patients that present within the influenza season, while they are undergoing PCR evaluation for influenza as a etiology or contributing factor to their sepsis, they should be receiving oseltamivir or Tamiflu. For patients that present with sequelae of staph or strep toxic shock syndrome, they should additionally receive clindamycin for decrease in toxin production in this entity. And then for patients who are presenting in an area with high prevalence of malaria, they should receive hydroxychloroquine while evaluation is ongoing. So these hard and fast guidelines are very helpful in terms of determining empiric antibiotic coverage for a large number of patients. Now, after initial therapy is decided upon, the guidelines recommend subsequent reevaluation of your antibiotic coverage on a regular basis. And this is in order to build a targeted and definitive treatment plan for these patients. So after microbial identification, or perhaps using indirect clinical information such as trend of inflammatory markers, improvement or worsening, these patients should have their antibiotic regimens evaluated after no more than 48 hours. And the reason for that is that we're trying to attenuate the side effects and toxicities that go along with the antibiotics that we use, such as nephrotoxicity. We're trying to limit the development of C. diff or fungal infections in these patients. Also, globally, thinking about antibiotic resistance and the development of that. And then there is concern that the alteration of the microbiome by antibiotic regimens can have significant impacts upon pediatric patients. Next recommendations from the campaign are that patients who have either immunodeficiency or high risk of multidrug resistant organism should receive empiric multidrug therapy. And so that is for two reasons. These patients who either are immunodeficient or at high risk of multidrug resistant organism can benefit from multi-drug coverage, and this comes mostly from the 2017 guidelines for treatment of patients with fever and neutropenia. And so the recommendation there is that these patients should receive anti-pseudomonal coverage. They should receive a fourth generation cephalosporin or a carbapenem in addition to gram-negative double coverage. And they found that this has a significant increase or effect upon the mortality of their patient population. Additionally, empiric multidrug therapy should be used for the effects of synergy for more virulent and tenacious infections, such as those that are associated with indwelling medical devices, such as central venous catheters, those patients presenting with endocarditis, those with group B strep sepsis, and those with risk of carbapenem-resistant Enterobacter infections. The next recommendation from the campaign is that special attention must be paid to the dosing of antibiotics in sepsis. And that is to say we have to pay attention to the pharmacokinetics of these drugs, and that is the movement of drugs through the body. And so the pharmacokinetics of antibiotics in sepsis can be altered based upon a number of different things. First, the volume of distribution of a patient who presents with septic shock can be increased due to fluid therapy and fluid resuscitation, or additionally capillary leak, which occurs in endothelial dysfunction in sepsis. Additionally, patients with septic shock often have decreased clearance of antibiotic agents, and this can be due to both renal and hepatic dysfunction, or it can be due to decreased albumin levels from inflammation, which leads to less protein-bound drug and rapid clearance that way. So, taking into account the pharmacokinetics of the drug and the patient's state, including their volume of distribution and drug clearance, we have to determine antibiotic efficacy. And so this can be monitored by analyzing kind of the characteristics of your antibiotics that you're using. So for those antibiotics that have time-dependent action, require time to kill their pathogens, such as beta-lactams and clindamycin, there is some evidence recommended by the campaign that continuous or extended infusions plus or minus loading doses may be an efficacious way to improve the efficacy of their antibiotics. For antibiotics that are concentration dependent, such as aminoglycosides or metronidazole, it's important to monitor both peak and trough levels to improve efficacy and limit toxicity. And then for those class of drugs that are concentration dependent with time dependence, in particular vancomycin, there is some evidence to suggest that continuous infusion of vancomycin may be somewhat efficacious in improving your antibiotic potency. Additionally, regarding antibiotic therapy, the committee makes a recommendation to make a daily assessment for de-escalation of antibiotic therapy. And the way we can achieve this is through a number of different ways. There have been several adult studies out there that have shown that the use of procalcitonin has successfully guided antibiotic therapy and been able to help in terms of de-escalation of therapy. And additionally, procalcitonin has actually been shown to decrease mortality when used in these patients. There has also been some proponents of antimicrobial stewardship programs who have been able to decrease antibiotic usage without affecting any change in patient outcomes, so without worsening patient outcomes, I should say. In terms of de-escalation planning, determining the duration of an antibiotic course is the key right there. So this is basically determined by looking at several different factors. The first is the site of infection, the second is the etiology of the pathogen, and the third is the host's intrinsic response. And so looking at the site of infection, patients that have either a high pathogen burden or poor antibiotic penetration of the site of infection will likely need a longer course of treatment. And so this can include associated biofilms or infections with biofilms, such as those infections including endocarditis, patients who have an abscess or suppurative infection, or those patients who have an appliance or a prosthetic joint. In terms of the etiology of the organism being treated, resistant organisms likely require a longer course of treatment. And so that in particular goes for methicillin-resistant Staph aureus versus MSSA according to the guidelines. And then finally, we look at the host intrinsic response. Those patients with immunocompromise may require longer courses of treatment because of their decreased intrinsic host response. And so in particular in neutropenic patients, there is often a recommendation to treat with antibiotic coverage until neutropenia is resolved. Now, an important note that was made by the campaign here in this section is that the degree of organ dysfunction is not necessarily indicative of a need for longer duration of antibiotics. And so these two factors are not related and should not impact upon your decision of the duration of your antibiotic course. The reason for such attention to this point is that there are a lot of adverse effects associated with antibiotic therapy, and particularly in pediatric patients and those who are very low birth weight infants. Those patients are more susceptible to NEC or NEC. Hospitalized pediatric patients who undergo unnecessarily long antibiotic courses are also susceptible to fungal infections. And then, of course, globally, we worry about the development of antibiotic resistance. Finally, in this part today, we'll be looking at source control. And so source control is essentially simply defined as the control or removal of the source of infection causing septic shock or organ dysfunction. And the reason for this is that source control is needed to prevent spread of the infection. So usually this takes place in the setting of drainage of a source of infection, either a percutaneous or deep abscess, a lung-associated empyema, perhaps a septic joint, or in the case of osteomyelitis, a subperiosteal abscess. And the reason you need drainage in these situations is that these areas are poorly penetrated by antibiotic coverage. They can cause ongoing hematogenous spread in the bloodstream, and as well as ongoing inflammation. And so removal or debridement is important in these situations, particularly in patients who are neonates, who have an associated fungal infection or an Enterobacter infection. There is some allowance, according to the guidelines, to treat through an infected line, for example, in patients who have a certain set of characteristics, including those who have an infection with identified coagulase-negative staph, those patients who have identified gram-negative rods, for example, and of course, patient has to be clinically stable in order to allow for treatment through an infected line, not necessitating immediate source control. And so that concludes part one of our lecture. Next, we'll be looking at fluid therapy and other elements of the treatment of septic shock and sepsis-associated organ dysfunction.